This is an intumescent cataract wherein I have done a phaco, and I have actually aspirated. This is one of my old cases. I have actually aspirated and decompressed this lens with a 26 gauge needle prior to doing my capsular rhexis. I don't do this anymore. Although this has been shown by many surgeons to be very effective, it's not very repeatable, and so I think the best way is to go with a double rhexis or a spiral rhexis. So having said that, I'm just going to demonstrate this case. So here's a regular intumescent cataract, and I'm going with my 2.2 millimeter keratome, two side ports. I go ahead and put in some air. You can see how intumescent that lens is. The air is hardly staying in there. I then stain the capsule with trypan blue and express the blue as well as the air with HPMC. I have now taken a 26 gauge needle, gone into the capsule, see how, and I am aspirating all the cortex. And notice in this case, when I aspirated, even the peripheral cortex came, and that is why when I went ahead with my capsulotomy, I was able to get away without encountering the flag sign. Still a bit difficult to initiate my rhexis with a cystitome, but I have managed. One could use a microrhexis forceps in such a case, but however, since the cystitome was working, I went ahead with it. You can still appreciate it's not very easy to control this. So you have to be a bit careful. That's it. There is no need to do any hydrodissection. I go ahead, put in some HPMC and take a very sharp chopper in my left hand and my phaco probe in my right, and proceed with the chopping technique. Just aspirating some superficial cortex. And this is the classical woodcutter's chopping technique, or a vertical chop, direct vertical chop. So these nuclei are very mobile, so sometimes difficult to control them. However, things seem to be going well. So that's the third chop, trying to rotate it. Just removing all the superficial cortex that is just kicking up. It's making my job a little more difficult, and this is more of a quick chop method. I still have some central spine left. And you can see that there are some attachments in the center. However, there are some fragments that I can remove. trying to get rid of that central attachment. Not very easy. It's down there, and we have got a fragment, trying to create some space, and that's one heminucleus done. And watch what happens to the other. Still attached. This by no means is easy, so I come out, put in some HPMC and probably some higher molecular weight HPMC, and trying to get out the piece and trying to chop it there. Even then it is so leathery. This patient also happens to be a diabetic. I'm just trying to get bits and pieces of it and see actually and look how it has tumbled over. And this is the surgery from where I actually got the idea of flipping over the nucleus. See, once this has flipped over, I can get at the spine, and look how easy it has become. Till then I was actually struggling to get out the pieces, and now once it flipped over and I got the backbone, that's it. The whole thing came in just like butter. Just cleaning up the little bits and pieces here and there, and that's done. And after cleaning up the cortex, I go ahead, put in my single piece foldable IOL within the bag. It's not in the bag. I'm going to tuck it in with the dialer. So the important step that I wanted to show was that flip. After the nucleus flipped and I attacked the attachment at the back, that is when the whole surgery actually became very easy. That's the whole point of showing you this video. Thank you so much for watching.